Thank you. All right. Yes, as Sue mentioned, I'm Dr. Casaubon. I'm one of the breast surgeons here working at Baystate. I've been here for about 4 years now. I work with a really great team consisting not only of a couple other surgeons who have specialized into the surgical management of breast cancer, which is the point of the talk today, but we also have a breast surgery fellow who is a general surgeon who is training to do what we do. And we also have, let's get the slides going, a great team. We've got nurse navigators, nurse practitioners, and many other excellent staff members who take care of our patients who have been diagnosed with breast cancer or have other breast concerns. If you've made it to this lecture, then you've no doubt heard about the other presentations that Baystate is putting on this October, which is Breast Cancer Awareness Month. They're being hosted by some of the other physicians and providers that contribute and are essential to the care of women who have breast cancer. For example, hopefully you made it to Dr. Ajaba's lecture about the importance of mammograms last week. And one of the presentations that I'm most excited for is coming up on October 30th. It's given by our newest medical oncologist, Dr. Parthna Bardwaj. It's about something called precision medicine, which is one of the new and exciting areas in the oncology field. It's essentially about using individualized treatments to fit each patient and offer the best outcome. It's like matching the right treatment to the right person. So I think that's really exciting what's going on there, and I'll probably be attending that one myself. But today the talk is about surgery. Because the treatment for breast cancer almost always involves a surgery to remove it. It's one of the oldest, most enduring, and most trusted treatments for breast cancer. I would guess that the first thing that people think about after hearing that they have breast cancer is whether or not it can be removed, and if so, how soon. So let's talk about that removal tonight. Many of you have heard the terms lumpectomy and mastectomy, but for those of you who aren't familiar, I'd like to first explain. Lumpectomy is a surgery that removes just the area of the breast that is affected. We target the cancer and excise it with a rim of healthy breast tissue, which is called the margin. Lumpectomy is also referred to as partial mastectomy or breast conservation. The pros of lumpectomy are that it leaves the rest of the breast alone and intact, which tends to be the most comfortable or most natural feeling. The cons are that occasionally we find that the cancer extends to or is touching one of the edges or the margins of that piece that was removed during lumpectomy. When this is the case, we can't be sure that the cancer is completely gone. Unfortunately, we don't get these results at the time of surgery. It's a little bit more complicated to evaluate breast tissue than something like the skin during a cancer removal. So we occasionally get these results later and then need to go back for a second surgery to clean out these margins. That second surgery is called a re-excision, and it's required somewhere between 15 and 20% of the time after lumpectomy. It does tend to be just a little bit easier for the patient to get through, but I think it's frustrating. People come out of surgery being really hopeful that all of the cancer has been removed. So when we find out later that one of the margins isn't clean and we need to go back and take more, I think it's almost like a blow to people. The second downside after a lumpectomy, there's a slightly higher chance of the breast cancer coming back, even when we get it cleaned out with negative margins. Because of this, we will often offer patients radiation to the breast after lumpectomy. Radiation can be done a few different ways, but the most common is to start about a month or so after surgery. Each treatment only lasts a few minutes, during which time energy is delivered externally to the breast, but it's done 5 days a week and often lasts around 3.5 weeks, depending on the findings of surgery. Radiation does work well and cuts the chance of the cancer coming back in half, which is why we pair it with lumpectomy to give us the lowest risk of recurrence. Radiation does cause most people to feel tired, and it can cause like a sunburn-like effect of the breast where it turns red and feels hot and feels angry. But most people do pretty well with radiation for the breast and do get through it, and those symptoms improve. It is another treatment, though, and I think between that and the chance of positive margins with the initial surgery, some patients are motivated to explore other options. The other option is called a mastectomy. Mastectomy is a surgery that removes all of the breast tissue. The pros are that there is a much lower risk for needing another surgery to go back and clean out the margins, like with lumpectomy. We also often don't need any radiation after mastectomy. Radiation prevents the cancer from coming back in the breast, but after the breast is removed, this is no longer necessary. That said, there are still occasions when patients do require the radiation after mastectomy, such as if the cancer has spread up to the lymph nodes, for example. So this isn't really a rule that choosing mastectomy means no radiation. When patients do choose mastectomy, they have the option of speaking with a plastic surgeon about breast reconstruction, which is rebuilding the breast. This can be done either with the patient's own tissue, moving tissue in from different parts of the body, or with an implant. Reconstruction can often be started at the same time as the initial mastectomy procedure, but sometimes it's performed at a second surgery when all of the cancer treatment is done. And most reconstruction involves at least 2 surgeries. So, if your goal is to avoid a second surgery in thinking about like a margin re-excision, often going for a mastectomy and reconstruction doesn't help you with that process. But I think it's important to stop here and make a point. Someone listening to this might interpret this as me saying that mastectomy is recommended because there's a slightly lower chance of the cancer coming back, and we have this ability to try and recreate or rebuild the breast with reconstruction. There have been multiple studies looking at thousands and thousands of women, basically since the 1970s. That's when the first of these studies came about. And they've all showed the same thing. They found that as long as the cancer can be completely removed with the lumpectomy, the patient is going to live for the same number of years. That is to say that choosing the bigger surgery, mastectomy, isn't associated with living longer. This idea of how long someone is going to live after a cancer surgery is called survival, and it's one of the factors that we have the best data on because of all of these studies. One of the reasons that survival is likely the same between the two is because if breast cancer is going to come back after lumpectomy, it usually comes back right in that same region where the tumor was removed initially. Occasionally, lumpectomy can be performed again. You go back in and try and remove the cancer again with clean margins. But most commonly, when the cancer comes back after lumpectomy, mastectomy is then recommended. So it's kind of like we tried, came back, okay, it's time. This isn't for everyone, but this is how the discussions often look. So if that happens, patients end up in the same place. And I think that's part of why the survival ends up being equivalent. So I want to be very clear in that we support our patients and encourage them to make the decision that's right for them. It's their decision, not ours. We trust the data that came out of these studies, and we trust that either option is safe. But I will say that it's the opposite, actually. We don't typically recommend that someone have a mastectomy. We actually usually recommend for women that are candidates for both that they have a lumpectomy. One of the downsides of mastectomy that I didn't previously mention is that the chest often feels numb afterwards. So if the breasts are a part of intimacy before surgery, this will often go away after mastectomy. And this is the same with or without reconstruction, though I've heard people even describe the chest being less comfortable after that reconstruction, I think, just with all of the surgery and everything that happens afterwards. But unfortunately, not everybody is a candidate for lumpectomy. And so I think that's one of the big things that comes up in this discussion. It's lumpectomy versus mastectomy, but not every person has this option. For example, lumpectomy really only works if we're able to remove all of the cancer from the breast while still leaving a meaningful amount of breast tissue behind. So the problem is sometimes when the cancer is discovered, it's already in multiple areas of that breast. And so it's not possible to remove it and save any of the breast tissue. Because of this, our ability to perform mastectomy often comes down to the patient. And I want to recognize that I'm very aware that oftentimes things don't go as planned. But how we most often see this is when people are getting mammograms, we can sometimes detect the cancer early when it's just in one area of the breast. It hasn't spread throughout multiple different areas of the breast. This is Breast Cancer Awareness Month, after all. So there's no doubt you're seeing the pink ribbons and you're hearing the stories of survivors. But one of the main components that goes into this is the early detection that happens with mammograms. So it's actually recognizing that and then going out and doing these mammograms. Again, I will say that sometimes it doesn't work like that. We have someone who's doing their mammograms every year, and we all of a sudden look one year and the cancer is spread throughout multiple parts of the breast, and we don't have this option. But when it works as planned, it's very nice to have the different surgical options. It goes the other way too, though. The mastectomy itself is a longer procedure. It's more invasive. There's more risk that comes with it. Higher risk of bleeding, higher risk of infection. And so for a lot of patients, this is actually too much surgery for them to get through. And so this might not be an option for them. After a breast cancer diagnosis is made, typically the first visit that patients will have is with the breast surgeon, where the mammogram and the other images can be reviewed, and we can perform an exam to determine if we have both of these options and which option is best. For patients who do require or choose to undergo mastectomy, there are different approaches. There's different ways to do a mastectomy. The first is mastectomy without reconstruction. And that is, I skipped a couple slides here, so let me back up. This is just from one of the studies looking at survival, showing that picking more aggressive surgery like mastectomy doesn't mean living any more years. But one of the things that I wanted to bring up is that we are hearing more and more people who need a mastectomy or are choosing to have a mastectomy come and ask us about going flat. On the internet and in the media, you will find a lot of information about the go flat movement. And this is certainly your choice. And so one of the things I want to say is that if this is something that you're thinking about, your surgeon should be able to answer your questions about this and should ultimately support you in this decision. If you decide to rebuild the breast, there are also a number of different ways to do that. I mentioned that it can sometimes be done with the person's own tissue, moving it or rearranging it in, or sometimes it can be done with an implant. In the United States, the implant-based reconstruction is the most common. So most women who are having breast reconstruction after mastectomy in this country are getting an implant. And again, there are some different ways to do this. One of the most common ways is called a skin-sparing mastectomy, where we try to save as much of the skin as possible while removing the breast underneath, and then using that same incision to go in and put that implant in there. So this is kind of like a somewhat censored, I hope tasteful photo of what that might look like. Occasionally, patients who are undergoing mastectomy with reconstruction may be candidates for this type of procedure called a nipple-sparing mastectomy. Nipple-sparing mastectomy is something that's coming up a lot now. You're hearing about it more in the media, and people are talking about it. People are coming in to see us, asking about the nipple-sparing mastectomy. So it is a newer technique where we use a hidden incision underneath the fold of the breast. Usually it can be done a couple of different ways, but this is probably the most common. You use this hidden incision underneath the fold of the breast where you're not going to see it when you're looking in the mirror. And then all of the skin and the nipple and areola up front are just left right in place. Then reconstruction is done from that incision underneath. So this ends up looking the most natural of all of the different ways to do the mastectomy, but it doesn't work for everybody. So many people aren't candidates for this. For example, one thing that happens often is people come in with a cancer located right underneath their nipple. And so it's really difficult in that situation to try and save the nipple and think that that's going to be safe. So that's, again, going back to this idea of meeting with the surgeon, doing the exam, going through the pictures to see what the options would be. There are also some different ways to do the lumpectomy. Here at Baystate, we actually specialize in a number of these techniques. One of the new ways to do a lumpectomy is called an oncoplastic reduction or an oncoplastic reconstruction. This is a procedure for women who are hoping to have smaller breasts, which sit higher up on the chest. Imagine or think about something like a breast reduction or a breast lift, but also at the same time removing the cancer. We approach this as a team with our plastic surgeons. We work together in the operating room, and I think we do really well with this. I think this is probably a good time to stop and say that we do have a very strong plastic surgery department here at Baystate, and we frequently will work on all of these procedures together that we've just mentioned, both the mastectomy with reconstruction, the oncoplastic reduction or reconstruction, and also for women who choose to go flat and have the most aesthetic flat closure possible. So I think I was moving a little bit faster than I initially planned, but with that, I just wanted to emphasize my take-home points from all of this. And the first really is that not everyone has this as an option. So, and I know that can be frustrating. Many people will talk to their family about their new cancer diagnosis, and you'll get a lot of input from the family. You should do a double mastectomy. You should do, just a lumpectomy because my friend had that and it worked. And it's difficult because a lot of breast cancer is different, and we often will find it in different stages and in different parts of the breast. And so again, you can't be sure that you're going to have both options. The surgeon is the person that's best equipped to discuss this with you. The surgeon should provide information that will help you in this decision. And after you decide, they should support you in that decision. I think that this is an important thing to emphasize also. When you get deeper into the media and social media specifically, you'll find stories of people who have had difficult relationships with their surgeons. The surgeon is telling them what they think is the best procedure, sometimes from an aesthetic outcome. And I think it's really important to have a relationship where both people are working together to achieve the best outcome. For example, it doesn't always work. Someone comes in and they only want a lumpectomy, but the cancer is throughout the whole breast. That's not going to be an option that's really safe. But, if a patient comes in and says, I want a mastectomy and I'm interested in being as flat as possible, the surgeon shouldn't say, okay, well, you need reconstruction or we need to do something different for you. Again, though, I will say that the survival or the number of years that someone is going to live is the same between the two options. And so while we don't try to push people to one way or the other, we do find that for women who are able to save their breasts, women who are able to undergo the lumpectomy, we recognize that they're just more comfortable after. And so after cancer treatment, they tend to report a higher quality of life. And we really value that. And one of the things that we worry about on the surgery end is that people will jump to this idea of choosing a bigger surgery just in fear of cancer. And it's totally understandable. But you think, I need to just do everything possible. I need to remove both breasts because I want to just beat this cancer and do everything I can. And so that's why we come back often to the studies that show you're going to live the same amount of time with either option, but you're probably going to be more comfortable if you pick the smaller option. So chances are, if you ask us for our recommendation, we're going to say lumpectomy, but again, it is your choice. And so if you choose to undergo mastectomy, you've got different options, different techniques, and it's really about just having this open dialogue with the surgeon to figure out what's best for you and what options are even out there. So I think we're a little bit ahead, but in order to leave a generous amount of time for questions, we can probably move on. I'd like to first just thank everyone who attended. Many of you know someone affected by breast cancer or have experienced it yourself. And especially during Breast Cancer Awareness Month, I know how hard it probably is to be hearing and seeing things so frequently. And I know how difficult it must be to make this decision, especially with all of the complexities that come with it. So I'll just end by saying that we're here for you if you need us or want to explore these options.
Thank you, Dr. Casaubon. That was well done, and I appreciate your time. There are a number of questions in the queue already, and I'll just begin with this one here where this attendee is asking, how are patients with double mastectomy monitored after the mastectomy?
Yeah, I think that's a really good question. One of the interesting things about choosing a double mastectomy is that we don't recommend for someone to have mammograms or any additional images afterwards. Typically, the only monitoring is a visit with either your oncology team or your survivorship team or someone in our breast office that will do an exam of the skin every year or every 6 months. But really no images are recommended. And I think as scary as that is, one of the reasons that's the case is because the chance of it coming back after the double mastectomy is so low that really you're not going to find much doing these pictures. There's also, after you've removed all of the breast tissue, you're not going to see anything with the mammogram. It's just going to be the skin and whatever's underneath.
Excellent, thank you. The next question is, this person's family members had a mastectomy with radiation, and they're wondering why someone would have a mastectomy and then radiation after that.
Yeah, that's a great question. So there are a couple of scenarios that lead us into needing both things. And so I'll go through them all. The most common reason why someone would still need radiation after mastectomy is if the cancer has already spread to the lymph nodes. This tends to be something that sets off a little red flag for us. We say, hey, this cancer was spreading. We need to be a little bit more aggressive than we would normally be, like it was spreading outside of the breast. So just removing the breast with a mastectomy might not address that well. And one of the things that radiation does well is it covers the entire area very well and decreases the chance of the cancer coming back. So radiation is something that's often done for women who have cancer that has spread to a lymph nodes. There are other scenarios that are similar in that you're thinking, whoa, there was a little bit more cancer in there than we were thinking about. Like, what else can we do to make the risk of this coming back so low that we don't have to think about it and we don't have to worry about it? So women that have very large cancers or cancer that is in the skin of the breast before mastectomy, or if it's like grown into the muscle behind the breast, these are all situations where we're just a little bit more worried and we want to do the right thing and really protect the patient against recurrence. So we do radiation. Every once in a while, it is a margin thing. It's pretty rare, but there are times when there's so much cancer in the breast that even with the mastectomy, we can't get it out with clean margins. And so radiation is great for those scenarios because it's going to go and protect any of the tissue that's left behind from having the cancer come back, because radiation, while difficult, does actually work. So those are the scenarios.
Excellent, thank you. This is more of a comment. Dr. Casaubon, you recently did a mastectomy surgery on a family member, and you took such good care of her, and they want to thank you.
Oh, thank you.
Next question. Does staging influence which procedure you might have?
Oh, this is a good question. Because this is where it starts to get really confusing. And we've actually got some things that I didn't even get into today. So stage itself comes from a number of different factors. The first is, how big is the cancer in the breast? The second is, did the cancer go anywhere else, like the lymph nodes? And so one of the common misconceptions is that if the cancer has spread to the lymph nodes, mastectomy will be required. It's like the cancer spread, so you've got to do more surgery. But that actually isn't correct. So if the cancer has spread outside of the breast, it doesn't matter what surgery you do into the breast. What matters is you've got to probably remove those lymph nodes and then do the radiation. And many people would do chemotherapy because, again, you want to be really aggressive. And so removing more breast tissue isn't going to do anything for the lymph nodes. They're higher up under your armpit. So then the question comes to, okay, well, if the lymph nodes don't affect the decision, what about that other thing you said, the size of the cancer in the breast? And this does. For example, if you've got someone who has a large tumor in the breast and a smaller breast, it's going to be really difficult to get that cancer out, which is the main goal. We want to, remove it all and save you. But it's hard to do that with leaving any breast behind. So this actually puts us in a place where we've still even got some other options. For example, sometimes in this case, we will start with a treatment to shrink the tumor. So let's say you come in, large tumor, small breast, but you really want to save your breast, which we understand. So we say, okay, let's start with chemotherapy, or there are some hormone treatments that take time, but would shrink this down and make it easier to save the breast. So yes, that is, I think, a really important thing to think about. But in thinking about stage and mastectomy, it's important to recognize it's not just the size of the tumor itself, and it's not just the size of the breast. It's also how many parts of the breast are involved. So you might only have a 1 millimeter area of cancer, but let's say you've got a couple of those and they're spread throughout the breast. Then there's no real safe way to say, okay, we're just going to go remove all of the little areas. And so that's one of the big things we're thinking about. Like, is this a cancer that's spread throughout the breast where it's just not going to be safe to try and leave any of it behind? And that's not really a stage question, but that's one of the things that's really important. Like, if you have only 1 millimeter cancers, your stage is still going to be low because, again, we said it's based on the size, but still we've got to get it out in order to help you.
Well, thank you. And knowing that may be the same response for I guess the next part of the question, which was, what stage are most patients at when having either surgery? But it sounds like stage isn't really the number one requirement.
Yeah, it's not. And nowadays, I think we're a little bit better at recognizing that higher stage can be managed with some treatments beforehand. Like, bigger tumor in the breast can be treated up front, decrease it, and get us into a different position. But I will say that there is a component of that you need to recognize, and it's that often higher stage will come with additional areas of disease. So it's not just the one measurement. If we're finding it late, there are often times when it's in a couple of different parts of the breast and it becomes tricky to really safely remove it all. So I think that is important. Higher stage is probably associated with a higher risk for needing mastectomy.
Thank you. The next question, how long after treatment can you pursue plastic surgery?
That's a great question, because you can start even before you have the mastectomy. So many times we'll see somebody and they will be interested in having breast reconstruction. And so we'll get them over to the plastic surgeon beforehand, and we'll sometimes plan a combined procedure where we work together. The breast surgeon would remove the cancer, remove the breast if needed, and then the plastic surgeon would either rebuild the breast that's left behind, like with these oncoplastic reconstructions, or start the breast reconstruction itself, put in an implant. I will say, though, that a couple of things come up here. I mentioned this, but usually the reconstruction is a two-step process. So the most common thing that you will see for this is with mastectomy and reconstruction anyway, is that the breast will be removed and then a temporary implant will be placed. They call this an expander. But what the temporary implant does is it just kind of holds the place of where the reconstruction is going to go while you finish up the rest of the cancer treatments. It's a lot of trauma to the body to try and do a mastectomy and then do a reconstruction, like the full reconstruction right at the same time. So this kind of puts us into this stepwise process where we can control it a little bit better. It's a little bit safer. It's a little bit easier to build the breast back up how you want it for the reconstruction. That temporary implant will often have the ability to change size. And so you can, with a little injection, increase the size of it until it's the size that the patient wants, and then go swap it out for the primary implant or the permanent implant. But sometimes reconstruction's done after, and there's not a good timing, but the more cancer there is, the more we tend to say, okay, let's split it up. Let's deal with the cancer first, especially if it's like in the skin or something like that, where we're concerned about trying to just make sure we're getting everything out. Let's get through all of that. If you need the radiation still after mastectomy, let's do the radiation. And then when you've healed up from everything, let's go ahead and do the reconstruction. So it depends a lot on just the patient, how much cancer is in there. But yeah, sometimes it can happen at the same time. Sometimes, let's say someone needs chemotherapy after the mastectomy and then they need radiation. That's going to be a situation where you're like, okay, we probably need to wait like a year. You really want to let people heal up after radiation before doing anything. So those are the slower ones.
Thank you. The next question, does Baystate provide tattooing, or do you recommend someone to provide it?
That is a great question too, because we have a resource that I feel like isn't used as much as we hoped it would. We actually have a woman who specializes in chest tattoo after mastectomy, specifically the 3D nipple and areolar tattoos, and she comes and will do this. She'll do these procedures in our office here in Springfield. And so for us, we were like, oh, this is so exciting that we can offer this to patients. But I don't know if we're not getting the word out there well enough, but I haven't seen a lot of people taking us up on that. But yes, we do that, and we do it here. We also have another woman that works here in our office on Wasson in Springfield, and will build custom prosthetics for patients, just like an external thing that goes in your bra to look like the shape of a breast. So she will do those here too. And I think we do well with utilizing her. She'll also help build custom bras for people after either surgery, and get your insurance, usually, knock on wood, get your insurance to pay for all of this.
Wow. Well, thank you for those great services. That's awesome. The next question, are more lymph nodes taken for a mastectomy versus a lumpectomy?
It all depends on the patient. And so the most common thing to do for the lymph nodes while we're doing these surgeries is to inject the breast with a dye that will map out the lymph nodes that are draining fluid from the breast itself. The reason we care so much about lymph nodes is in this fluid is breast cancer, if it's going to spread, it goes with that fluid and it goes up to those lymph nodes. That's how it gets there. So the amount of dye or the amount of lymph nodes shouldn't matter at all depending on lumpectomy or mastectomy. It more just matters about patient's anatomy. For example, sometimes we inject that dye on one person and they've got 10 lymph nodes that light up. And we say, okay, well, any of these 10 lymph nodes could have cancer because the fluid is going to all 10 of them. So we're like, we have to take out all 10 to be sure it hasn't spread. Some patients, we inject the dye and it goes to one lymph node. And we say, okay, well, we need one lymph node because all of the fluid from the breast is going to that lymph node. And again, cancer goes with the fluid, so we need to know what's in the one that has the fluid.
Oh, thank you. Next question. Can you have radiation with an expander in?
Yes, it's a little tricky because it'll come somewhat down to the radiation doctor and somewhat down to the plastic surgeon, but the answer is yes, it is possible. And actually, that's one of the preferred ways of doing it because it's a temporary implant. So doing radiation with it in there isn't going to cause you any problems. For example, one of the things that will sometimes happen when you radiate implants is you get scarring around it. But because it's a temporary implant, you're going to go back and remove it and can deal with that scarring at the time. So yes, it's possible, but every radiation oncologist and every plastic surgeon is a little bit different, and they have to be the two to say yes or no, we should do this.
Excellent. Wow, these have been some great questions and really some terrific answers. I learned so much. I don't believe there's any more questions, but we can just give it another pulse and in case there's any more that the audience has. But I want to thank you, Dr. Casaubon, for this great talk and for this great Q&A. Really appreciate you and our audience. Thank you.
Yeah, those are good questions.
Yeah, I don't see anything else coming in, so I think we'll end there. And I want to thank our audience and thank you, Dr. Casaubon.
You're welcome. It really is it's a difficult decision, and it's a little bit different for every single patient. So even I think you have to take what I say with a little grain of salt because every situation is so different. I think that's one of the things that we do really well here is just approaching these different situations and trying to make the best plan, almost like that precision medicine talk that's coming up in a couple weeks. But it's a little bit different for everybody. So
Yeah. Well, thank you. Well, we'll see you at the next event. Appreciate you.
All right, and reach out to us if anybody needs anything. We'll be over here.